So yeah, I'm Nadine Chang. I'm a psychologist here at Gracie Square Hospital, which is an inpatient psychiatric hospital in New York City. We're affiliated with New York Presbyterian Weill Cornell Medicine. I am also the chair of our Asian Psychiatry Program Committee, where we focus on tailoring our psychiatric inpatient care to patients who identify as Asian and Asian American, and also I coordinate all of our community outreach to Asian communities. So happy to talk to you today about Asian American mental health. I'll go over sort of, a bit of a broad overview, and I'll end with, I think, a case example of one of our former patients here at the hospital, which sort of illustrates the factors that I'll be talking about that affect Asian American mental health. So, and then we'll have time at the end for questions. Okay, so getting into this. All right, so I think many of us are aware that and I'm going to say, so when I say Asian American, it's Asian American, Pacific Islander, Native Hawaiian, so everything, I'm just going to say Asian for brevity. But I think many of us know that the AAPI population in the US has increased pretty significantly, 88% over the past 20 years. And then I have a little bit of a breakdown of the different ethnicities. And just my point in showing this these statistics is that just generally, as the number of Asians in the US grows, so do their mental health needs, right? So this is definitely a significant proportion of the US population that also has mental health needs, just as every other demographic does. Okay, so just overall general mental health statistics. About 1 in 5 people have trouble with their mental health, right? That's over, 43 million people. Think about it sort of, thinking about the people that you know in your life, right? If you know people who are left-handed, more people in the US have mental health problems than there are lefties. So why do I say this? Because I want to show rates of mental illness by race. And I'm going to say this a few times, that these statistics are inherently problematic and probably inaccurate, right? So we see here that the rate of mental illness in Asians is lower than that of other groups. However, I think the big question is that whether these differences are actually attributed to cultural differences in actually seeking mental health care, right? How do we know the rates of mental illness? We only know based on people who actually report it or, are seeking treatment for mental health issues, right? So that means a huge proportion of, I think, all populations, but especially Asian, populations are, unreported, right? So I always say, okay, I can give you all the stats that the CDC, shares, but I think it's not accurate. Okay, so just keep that in mind. But I think what is, a little more accurate is that Asians are, are the group that has the most, like the highest rate of underutilization of mental health care services. This is like time and time again, studies are showing this. And at least I think sort of the saving grace is that in more recent years, and especially in the last 3 years since the pandemic, more and more efforts are being made in community outreach about mental health issues. And then, organizations and healthcare systems developing more culture specific treatment programs, including not just multilingual clinicians, but clinicians who are able to, understand how culture impacts mental health and illness. So it's improving, I will say, but still a long way to go. Okay, so just so we're all on the same page, I want to just give like a sort of broad overview of like mental health and mental illness. And so I get this question a lot actually from community members, is what is mental health? And it's, general mental and emotional well-being, feeling okay. That's what I always say. You're just feeling okay with life and how things are going, and sort of, generally managing stress okay. But very much highlighting that it's not being happy all the time and not feeling perfect all the time and always being positive, right? And definitely not that. Obviously we're human, we have these ups and downs. So I like to contrast that with what is mental illness. And what it is not just having a bad day, right? It is actually like a medical disease that affects how you think and how you feel and your behavior, right? And to the extent, and this is like a question that I get a lot again from community members, is like, how do I know if it's like mental illness or just having a hard time? And that's really how it affects your day-to-day life, right? And the factors that contribute to mental illness are genetics, brain injury, biochemistry, traumatic experiences, all of the above, right? I'd like to really emphasize too that it's not just because of bad parenting. My mom did this, therefore I'm like this. And not just something that you can get over. And I think, especially with Asian cultures, it's sort of like, you're fine, right? Like, you know, what do you have to be depressed about? You know, you have all of this going for you. How could you be, you know, distressed or anxious or whatever, you know? And also, I think like really, at least like acknowledging the role of media in mental illness, and it's generally not just, you know, dangerous people. Dangerous person has mental illness, or, you know, a mental, you know, person with mental illness is dangerous. I like to review these facts specific, or these myths and facts, just mainly to address that. And because, you know, general population, a lot of people do believe that people with mental illness are violent, and that everybody needs to be hospitalized if you have a mental illness, right? And there's nothing that you can do, right? And actually, I work in a psychiatric hospital, so I do see people who are in acute need of psychiatric treatment. And I do see patients who are violent, but this is such a small proportion of people with mental illness. I think these statistics should be more accurate. 3 to 5% of violent acts are by people with mental illness, but the media would not um, indicate this, right? Because of course it's highlighted on the news, it's highlighted all over social media too, whenever there is an act of violence by someone with a mental illness. But this is very much in the minority. And in fact, you know, especially like the patients that I work with who are pretty ill and pretty impaired, like they're much more likely to be victims of violent crime than actually perpetrators of violent crime. And something I'll talk a little bit more about later is that people with mental illness are 100 times more likely to die by suicide. And I'll go into why that is, but that is like a staggering statistic. Okay, so again, I'll just overview different types of mental illnesses, again, just so we're on the same page. And then I'm going to talk a little bit about how these categories of psychiatric illness may manifest in Asians. So we have our anxiety disorders, which is, you know, basically what it sounds like. It's sort of intense fear and distress, essentially to the level that it becomes so overwhelming that it prevents us from functioning in our day-to-day life, right? This is the most common type of mental illness. And these are some of the diagnoses that are within this category. So post-traumatic stress disorder or PTSD, obsessive compulsive disorder or OCD, panic disorder, social anxiety, and specific phobias. I'm sorry, I am in a hospital, so we have emergency calls. um, so depression, I think many people are familiar with, and I want to just, you know, highlight that it's more than just like feeling down or having a bad day, right? It's, you know, when your sadness actually becomes so overwhelming that it affects how you think about things and prevents you from doing everyday activities. So yes, we feel sad after a breakup, for example, right? But it may turn into depression if I'm not able to go to work, if I'm not able to, like, you know, if I lose my appetite, if I can't sleep or I sleep too much, those kinds of things. So like the things like when my areas of my day-to-day life are actually affected by the depressed mood or the sadness or just sort of like lack of energy or motivation. There are a few different types of depression. major depressive disorder, bipolar disorder, seasonal affective disorder, which we're in that high risk time right now for seasonal affective disorder with the change of seasons in New York. It's freezing today and dark already at 4 o'clock. Okay, and then psychosis, which is like also which actually is my area of expertise, is psychotic disorders. And it's when, someone's thoughts and perceptions make it difficult for them to recognize what's real and what's not real, right? So we'll see people who are sort of paranoid about other people, or maybe they're hearing voices or seeing things that aren't really there. And very fundamental in this category of illness is this lack of insight. So people with psychotic disorders very often are not aware that they have a psychotic disorder. And so this includes schizophrenia, schizoaffective disorder, bipolar disorder, and dementia. And I'll talk more about drug and alcohol use a little bit later, but again, about a little more than a third of people with drug and alcohol problems also have a comorbid mental illness. Again, I think this is also underreported, right? Because the drug and alcohol problems may overshadow the other mental health issues, right? But it's a very common sort of strategy for coping with mental health issues, even though in the long run, it doesn't help at all. It makes problems worse. Okay, so we look at this, right? So sort of general, descriptions of these different areas of mental illness. Okay, so I want to sort of highlight what we might see in Asians. Okay, now anxiety, I want to mention the term neurasthenia, which is sort of an antiquated term. I don't know if anybody's heard of this before. It's not really used anymore, but historically, anxiety in Asians was sort of characterized as like physiological, like manifestations of anxiety. So that could be like insomnia, or gastrointestinal upset, or feeling shaky, right? Or feeling nervous. Often we have complaints about, I have a weak heart, I have weak kidneys, I have, low blood pressure. My yin and yang is imbalanced. We might hear complaints about muscle soreness. And so those, historically were characterized as neurasthenia, again, which is like a physiological manifestation of anxiety. We still see reports of physical problems that are likely related to anxiety. Think about like when you're very anxious. I know I can't sleep really well when I'm anxious. I might have some like stomach upset when I'm anxious, those kinds of things. So this just might be more prominent in Asians, mainly because our patients might not say, I'm feeling anxious. They might say, oh, my stomach is upset, right? I don't have an appetite. So very similarly with depression, we'll see muscle aches, back aches, headaches, poor appetite, just again, sort of like, these physiological manifestations of depression, because how likely is it that someone might say, oh, I'm feeling sad, or I'm feeling like I don't have motivation? It's more about, oh, I have difficulty concentrating, I can't remember, and I don't feel like going out, I don't have the energy, right? And so this may be more prominent in Asians just because they may not be talking about like their emotions as much. With psychosis, right? Again, remember it's sort of like it's the thought process that's impaired. But my patients generally will say, oh, I just have, it's hard for me to concentrate on things. Or, you might see your family members often see like this irritability or sort of suspiciousness or social withdrawal, right? We often see problems with like, again, day-to-day functioning, like just like taking care of themselves, like hygiene and eating and sleep also. And so oftentimes it's the family members that will recognize these changes in behavior that may be indicative of a psychotic disorder. and with alcohol and drug use. So the rates are estimated to be similar, but at the same time, very, very, like much significantly lower rates of actual treatment seeking for substance use disorders, right? Again, because people aren't talking about the impairment related to drug and alcohol use. So all of this being said, these are just broad generalizations that I'm giving you. So it's all dependent on age, generation level, acculturation, education, and just stigma towards mental illness, right? So I will say, again, as a broad generalization, we have a geriatric program here at my hospital. So our older patients, especially Asians, will list all of these symptoms and not say I'm anxious or depressed, or paranoid. And then again, that's, I think, generation level, which relates to stigma. Whereas our younger people, we have a number of college students right now in our hospital and who are Asian. And they're much more open to the concept of talking about feelings and thoughts and feeling like, oh, I'm not doing good enough, or I'm a failure, something like that, which an older person might not feel comfortable sharing. All right, I do want to talk about suicide a bit just because it's not talked about a whole lot. So most people who die by suicide do have some sort of, mental illness or emotional problems. And if we think about why people do die by suicide, the goal is to actually end how terrible they're feeling, right? And combined with feelings of hopelessness and helplessness. So if someone is feeling, really sad, really like really down on themselves, and they don't see that there's any end in sight, then this is the end that they choose, right? And sort of not being able to think about their situation logically or rationally, that is a function of mental illness. So it's not just so snap out of it, look at what you have and everything's great. It's more of this person has depression, which also affects how they're thinking. So they're not able to see the better solutions, right? And I always give, and I give this information to everybody, like anybody who's having suicidal thoughts or any sort of behavior that is high risk, that is considered an emergency. And at the end, I'll share a lot of resources to help. Okay, so a couple more stats. About 34,000 people-ish in the US die by suicide each year. It's the 11th leading cause of death in the US. It's scarily the second leading cause of death in ages 15 to 34, so our adolescents and young adults. And actually older adults have the highest suicide rates across age groups. Okay, so I want to sort of show you where Asians fit into this. Okay, so the suicide rates in Asians is about half of that of the general US population, which also does include Asians. It's just the overall rate. It's actually the 8th leading cause of death in Asians, so it's like higher in that list for Asians. It is also the second leading cause of death in ages 15 to 34, so very consistent with the overall US rates. And this information, I remember when this came out, it was like a few years ago, was that, it used to be older single white men had the highest risk of suicide, and of older adults, now Asians have surpassed that. So now Asians have the highest suicide rates of the older adult group, which is concerning. But it's something that has changed over the last like 5 to 10 years, I think. All right. Okay, so I'm going to talk a little bit about cultural factors that affect Asian mental health. Okay, so these are factors that we consider and then incorporate into our treatment decisions here in our hospital. as well as just when we're providing mental health information to communities. So I think most of us know what collectivism is. It's prioritizing the needs of the group over individual needs. And so when we're providing treatment for Asians, it's really important to understand the role of the family for the individual, and the individual's role within the family system. Is this like, you know, is this the grandfather, or is this the adult child who's caring for parents and children, right? Is this our college students, one of whom is an international student? Okay, what are the expectations for her within her family system, being the only one in the US and the rest of her family's in China? So understanding all of those aspects are really important and helpful in making treatment decisions, and really identifying what the stressors are and how to help with those. Sort of related to collectivism is, are the hierarchical relationships that we see in Asian families, just the concept of filial piety and serving our elders, and deference to authority figures, right? If my mom disagrees with something, likely I'm going to do what my mom says, right? Not my mom, but other people's moms. And this sort of like serves us well here in the hospital, because doctors are considered authority figures. And so if I'm, working with a patient and recommending, this and that, they will very likely follow what I say, right? So it's helpful within this setting, but then it could be, it could hinder treatment if a parent is not, or other authority figure is not in agreement with mental health treatment. We do see this a lot too. Okay. And then acculturation is sort of how much, or like what balance of like Eastern and Western values the person has. This includes like, beliefs about mental illness and other beliefs, language, customs, and then, different expressions of values and experiences, right? And how they're valued, Eastern versus Western cultures. I mentioned stigma a little bit earlier, and this is a very much a barrier in working with Asians in mental health, because we have to respect that the individual wants to save face, and save face not just for themselves, but also for their family, right? And so I just had supervision with one of my trainees just before this, and she's Chinese, and she has a patient, one of our patients, who, is basically denying experience stress or depression ever. But clearly he's in a psychiatric hospital, so there was some depression and distress. But he is not comfortable talking about his feelings, right? And we're theorizing that he really doesn't want to lose face or feel like, oh, I'm supposed to be, sort of like the patriarch of my family and be the breadwinner, and I lost my job, and I'm a failure, right? And just sort of that stigma. So he refuses to talk about feelings at all. So we're sort of we have to be creative and work around that. But stigma is a huge barrier to effective treatments for Asians. It's a continual challenge. And then finally talking about, or at least understanding, the role of cultural beliefs in understanding mental illness. And that could be like, beliefs about the causes of health or illness, mental health, mental illness, and treatments. There is a genetic factor in developing mental illness, but if we think about, oh, this might make my family look bad, right? If I have this mental illness, because then I had parents actually say to me, does this mean, like, their son, had a psychotic disorder, and they said, does this mean that our family is sick, right? Because there's that hereditary component to it. So just sort of understanding, these beliefs about the causes of health and illness is really important in order to provide like the most effective treatments for our patients. Okay, how are we doing on time? Okay, good. All right. I mentioned already some of the barriers. I'll mention a few more. Obviously, just feeling comfortable talking about your experience or your feelings is scary. It's scary for people who haven't done it before, right? And then, worrying about what other people might think about someone talking about mental health issues, or even what we think ourselves about people with mental health issues. And, oh, I'm not like that. I literally had a patient today who said, I'm not like that person over there, right? I'm a different, I have a different situation. So that also like causes some delays in treatment. And then just sort of general mistrust of mental health services. I will say, as someone who works in an inpatient psychiatric hospital, a lot of our patients have interactions with the police and legal system. And so there may be sort of a general mistrust of governmental agencies, including mental health services. And then just sort of, like I said in the beginning, while culturally tailored interventions are, increasing across the country, it's still challenging. It's still really challenging to find people who want to work in mental health care that understand like all of these cultural factors that we just talked about. And I won't even get into the insurance issue, but there's always, financial issues, like financial stresses related to specialty care. And then what's available, with insurance, and we have countless issues with Medicare and Medicaid. And then overall, and this is a lot of what we do with our community outreach, as well as with our patients and their families here in the hospital, is just education about the types of treatments that exist for mental illness, what medications are, what they do. There's so much stigma about taking medication for psychiatric illness. So we do a lot of education about that. And then just different types of therapies. And we, my example just from today about the patient who will not talk about feelings, right? And in therapy, it's expected that you talk about feelings. So he said actually to my trainee today, we're not having our session today. And so she sort of talked him into it and said, you don't have to talk about feelings. Let's talk about something else. And so he was able to open up a bit because they weren't talking about feelings. They were talking about, work stress and whatever it was. So these are some very common barriers that we do see in other like marginalized communities and underserved communities. But I always like to talk about this like within Asian communities specifically. And these are some quotes that I've heard from my patients that are also barriers to mental health treatment. One from, someone is not talking about how they're feeling. It might be because they don't know how to talk about how they're feeling, right? Is this sadness? Is this like, what is this? And a lot of people who, if you're not sort of, if you don't learn how to label your feelings sort of early on, it becomes harder and harder as you get older, right? And so like, oh, this sort of like lack of energy I feel is just me. I don't have any energy. There must be something physically wrong with me. Oh, maybe it's depression though, actually. And that lack of energy might be related to feeling like not motivated and depressed. So again, like, this is something that we encounter a lot. And so we do, again, a lot of education with our patients in terms of labeling their emotions and just very much normalizing that everybody has emotions and everybody has ups and downs. And sort of like minimizing the impact. And that's why I talk so much about like, if depression or anxiety or psychosis even is affecting your day-to-day life, like that's an objective indication that treatment might be needed at this time. So we hear things like, oh, I'm just stressed and tired. I just need to sleep more. This is from a patient I had a couple months ago. I'm just having a bad day. I'll get over it. Right. Okay. But the bad day turns into 3 months, right? That's an indication that it's actually a little bit more than having a bad day. right? There's nothing wrong with me. It's everybody else who's upsetting me, right? That's a little bit more challenging to work with. But we sort of, I sort of say, okay, what's the common denominator here? Okay, something is going on in terms of, how you're reacting to other people. And I hear this one a lot. If I tell anyone how I'm feeling, they're going to think I'm stupid or crazy. And again, like being concerned about others, interpretations of what our patient is experiencing. So these are all barriers that actually prevent people from receiving adequate treatment, and all related to like stigma, but also just like maybe not recognizing what they're experiencing. Okay, so I'm going to do my case example, but I want to just give a little bit of background about our hospital. So like I said, Gracie Square Hospital, and we're in New York City. Hospital's been around for a while. We do have specialized program tracks. So our Asian psychiatry program is one of these 8 tracks. So you can see these are the other specializations. So we do a lot to tailor our interventions to meet the needs of our patients, whether culturally or religious or diagnostically or whatever. Okay. All right. So I'll talk about this case. So she's a middle-aged, married Chinese woman. Her diagnoses are major depressive disorder and borderline personality disorder. She had been hospitalized several times sort of in a short period of time, a couple at a different hospital and a couple with us, for depression, and she was feeling suicidal, and she did attempt suicide, overdosing on medications. And what was notable about her case is that she pretty much the whole time denied feeling depressed at all. But she was very, very, very somatically preoccupied. So, and her preoccupation would sort of change over time. So like the first one was, she like couldn't breathe, right? And so she did have an inhaler, and so she would request the inhaler many, like probably 20 times a day, which is not indicated for asthma. So we had to sort of explain, like, you can only get it this many times, but we had the theory that her anxiety might be related to her difficulty breathing, right? But her solution was, I just need the inhaler, right? She also had another preoccupation with having like a dry sinus cavity. And so she had a nasal spray that, again, she also asked for 20 times a day. Again, not indicated, not medically safe either, because it was a steroid nasal spray. So, and then, then it sort of like transitioned to like constipation versus diarrhea, and it would go back and forth between constipation and diarrhea and requesting medication to treat these. And then, very, very concerned about her blood pressure and saying her blood pressure was too low, because she didn't have any energy, or like when she stood up, she would feel very dizzy. So taking all of these together, she didn't have all of these, like medical problems, because we had internal medicine, see her many, many times. And we could see that her concern with these like physical problems, these medical problems, would increase when she was feeling more anxious, right? And so whether that was like she just had a phone call with her estranged husband, or we were talking about sending her back home, and she really liked being in the hospital. Most people don't, but she really did. Then we saw like an increase in her preoccupation with these physiological symptoms during those times. Okay, so as we got to know her, we sort of uncovered several themes that likely were factoring into her illness and her presentation with us. So she was quite socially isolated. She only had her husband, but no family in the US, no social supports, no friends or anything. Her husband was the only person that she talked to or saw. And then because between that, her husband being her only like social connection, and then like being very deferential to her husband, which relates to the hierarchical relationships. Her husband, of note, she was in the hospital with us for 5 months and he never visited her, not once. But he was sort of trying to dictate the treatment. And so she was very deferential to him and saying, okay, whatever he says, I'll do, right? So he agreed to the actual treatment plan in terms of like medication and setting up outpatient supports, but he didn't actually himself provide any support. Meanwhile, the patient was saying, well, he says he'll help me. He says he'll help me. We sort of knew that he wouldn't. But she was just sort of saying, okay, you know, he's the boss, so I'll do what he says. And what he says is true. Another factor, or like the cultural beliefs that I mentioned earlier, both the patient and her husband had very, very limited knowledge about serious mental illness and any non-medication treatments. So like therapy or like any sort of like behavioral interventions. So obviously she experienced her psychiatric symptoms as physiological. And so from that perspective, it makes sense. If I'm having a physiological symptom, then I need to take a medication for it, right? Or I need a nasal spray, or I need the inhaler, or whatever, as opposed to addressing the anxiety that was triggering the physiological symptom. And then finally, the stigma, again, she denied having any sort of mental illness. She had no problems. She maybe had some anxiety, but definitely no depression. I think I mentioned a little bit earlier that her preoccupation with the physiological symptoms were almost delusional in nature. So she was so preoccupied with them that that's all she could talk about. And then her husband really wanted her to be discharged from the hospital because of the stigma of having a wife in a psychiatric hospital, right? So he sort of superficially was saying, yeah, I'll help her, and she's fine, actually, but then saying different things to different members of the treatment team. So interestingly, her social worker here in the hospital, he's Chinese, but her nurse practitioner is not Chinese. And so her husband would say something different to the nurse practitioner than he did to the social worker. And so we all work as a team. So obviously we noticed this conflicting information. But like this was quite notable that maybe he felt more comfortable saying, you know, being a little bit more forthcoming when he's speaking in Chinese to another Chinese person, as opposed to this, you know, white doctor and saying everything is fine and she's fine. Okay. So this case was a little bit challenging because she, again, I'm a psychologist, and so it's a little bit challenging because she was pretty unreceptive to any sort of psychological or psychotherapeutic interventions. I run a psychology training program. I teach doctoral students how to do therapy, and she refused every effort we made. I have students who speak Chinese, and she refused all of it because she was just focused on medications for her physiological symptoms. So what did we do? We had to work around this, right? Because she's not talking about feelings other than feeling anxious because she wasn't getting medications. So we had to be a little bit creative, but also, you know, figure out some workarounds that would actually help our patient. So the social isolation was actually addressed because she was, you know, on our Asian psychiatry unit. So we had other Mandarin speaking patients and staff, and she was able to sort of have some social interaction, talk with others. She made a friend who was another patient who was similar in age to her, and so they spent a lot of time together. And then she was able to do some of our group-based therapies, as long as they were nonverbal. So they're like more activity-based. So it might be like, you know, music or art therapy, things like that. Exercise group. So she was able to have some social interaction there, which likely fulfilled some need there that she was lacking in her home life. So in terms of the hierarchical relationships, the treatment team consistently provided her husband with updates. It helped that it was the social worker was a Chinese man, and so they were able to communicate pretty clearly and respectfully. And then, everyone came to the agreement that both, with like the continued inpatient care, that's why she stayed with us for so long. Um, so because she was pretty unreceptive to like psychological interventions and only focused on medications, we did emphasize more of the mind-body health, including use of pressure points. And so she, found a lot of benefit for like, pressing, was it this area for, I'm not good at acupressure, but this area for anxiety, or like constipation. There's a certain part of the body. So, we sort of encouraged her to do that if she found it helpful. And then we did seek medical consult from our internal medicine team when the physiological symptoms did sort of reach the threshold where it was medically indicated for some sort of intervention. And then stigma, like I said, continual barrier. So she still had total denial of any mental illness. So we worked around the stigma by providing support around like specific needs in terms of like, okay, she needs a doctor actually to go to her house because she doesn't feel comfortable traveling on her own to go to a doctor's appointment, right? So we set that up for her where like a team would go to her house to see her regularly, and then addressing like the asthma and the constipation versus diarrhea and the blood pressure, right? So those are all addressed individually as opposed to like this whole syndrome based approach, just because she was so rejecting of that rationale. So we said, okay, well, let's just, address A, B, and C here. Okay. So eventually she was stabilized, was discharged. Her home situation was again like unclear because I think her husband was not actually home very much. I think he traveled out of state for work. And so, as much as he said, okay, I'll take care of her when she's home, we knew that this was not like realistic, like actually based in reality. So we set up other supports for her to accommodate that without necessarily confronting the husband on this. Again, saving face and stigma and all that. So yeah, so knock on wood, she's doing okay now. But that's just like, I think, a nice example of like very prominent physiological symptoms of a mental illness, right? That is very common in our population. So I'm just gonna end with a couple of slides, and happy to share this information. I can send these slides to anyone who's interested. We do provide our patients this information. So, iPad and phone apps, like mental health apps, some are in English, some are in Chinese. And then just a lot of information on websites about mental health and illness and treatments in Chinese and in English.